Hello, everyone, and welcome to the Corpsmen Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This is Aebhric O'Kelly. This week, we are again with Tactical Medicine North. The Ukrainians are here in Pretty Bay, Malta. We were running a Tactical APUS training program, and we just ran 5 days of ultrasound training, and I would like to introduce you to our three guests.
Hi, my name is Anastasia. I'm Combat Medic from Ukraine, and I'm working in Tactical Medicine North, and I'm absolutely happy to be here again.
Hey, my name is Dima, callsign Morty. I'm also Combat Medic from Tactical Medicine North, working here from almost the beginning, and yeah, happy to be here.
Hi, my name Nadia, nickname is Sport, and I'm Combat Medic in Tactical Medical Nurse.
So you are putting together an idea, a training package for teaching eFAST to Combat Lifesavers who have 5 days of training and Combat Medic Corpsmen who have 63 hours of training. And this is insane. There's so many people listening right now who their eye is twitching. They're cringing. It says, impossible. There's no way you can teach eFAST to these non-medics. And what say you about that?
If people would pay me $1 every time saying that it's impossible to teach someone something, I would be pretty rich for now. Because in 2022, people were saying it's impossible to teach combat medics without medical background, medical education. How can you teach medicine people with, I don't know, like teachers or IT or whatever. So it is possible. That depends on your instructor level skill and how you can adapt to the level of the group.
Yep, totally agree for that. It's about what you're going to teach them. You don't need to be so deep in ultrasound, but they need to know like basics, and you're not gonna teach them how to recognize maybe some disease, but we need to know are there any free fluids, and it's not so hard to like show them the way how to understand this and provide this.
I think that you can explain good how some organs look like and give him some association. For example, a kidney looks like a bean. CLS and CMC understanding it's all time.
So these 5 days, you did the APUS course. So the first 2 days was just our normal bog standard austere pre-hospital ultrasound course. How was that for you?
Well, I visited like not a lot of ultrasound courses, but a few. And every time when you think that you know probably everything in this area, something pops up. So this time was the same. We had really interesting discussions, and that was really interesting for me as for instructor and as for a medic, providing ultrasound care at the point of injury, stabilization centers, and so on.
We're doing a lot of ultrasound exam on stabilization points on the front line. So you really think like you know everything about this, but all the time on each course you found something new, some tips and tricks that really help you in understanding of what you're doing. And when you're going to teach someone, it's really helpful to have like simple things that can like boost you as an instructor.
Yeah, I think that simple things that was given us on this course very help us in medicine space when we work as combat medic, and also as instructors for people on CLS or CMC level that haven't a medicine background. For example, home points, this is a place when you can always return when you get lost in the body.
So you're referring to the concept of home. So in the APUS course, we have a home base, a home for each of the eFAST locations. And the premise is that when you get lost, and I often do, you just go home. So go back to that same point and start over. And do you think that would be helpful for the CLS in Ukraine?
Yep, we already tested on our trainings. It's really helpful for students to have some strong base that they like. If they get lost, come back there, and it's not so hard to remember. Just simple things, simple words, and they really prevail in this. They just like grab the probe and make a real fast exam. Maybe the best result for these 3 days was 2 and 30 seconds for eFAST with really perfect images.
Hi. Yeah, home points is very cool because when the students don't understand what they must can see, how image reflected from the body, and they often get lost. It's very easy to get home and try it again when they find that they want.
I agree. We will definitely take it back to Ukraine to our courses. It works really cool.
So after the first 2 days, which was just the austere and pre-hospital ultrasound course that we teach all the time, you were then, all 12 of you were then fully qualified APUS POCUS professionals. And the next 3 days is where the rubber hit the road. So this was a concept that you wanted to create a curriculum that could be taught to a Combat Lifesaver and Combat Medic Corpsmen with very little medical training and have something stick. So you said you wanted a 1-day course. We created the Tactical APUS, and I convinced 36 Maltese nurses to come in and be your guinea pigs over the 3 days. So let's start from the beginning. What is the Tactical APUS course?
Well, you don't need all the knowledges in the world for that because you're doing only extended FAST, which is a trauma protocol, which can be applied pre-hospitally, even in the, well, probably not at point of injury because in a tactical environment, you're pretty busy at this moment. But after you finish your standard march pose protocol, you can go straight to the extended fast or just fast if you don't, if you're short of time, because that might be really valuable for you. Well, first of all, to triage your casualties if you have a lot, and also not just to use telemedicine and say something. In this case, you have a really good backup for quick decisions from another part of telemedicine.
Yep, we see that we can let's say do monkey medicine, just easier things that each provider can do, and they just need to make good work with the probe, make a good image, and send with the telemedicine. And someone on the other end can help to decide what they need to do. Maybe it's about triage, maybe it's about to give some blood products, or there's it used in Ukraine, maybe some drops from the drones, some supplies. So it's things that could help guys who stuck in a prolonged care and they need to make some decision. And yeah, that's why.
I think that it's a very good idea because if the patient have an internal bleeding, it's easy to teach combat medics and CLS providers to understand how free fluid looks like, and it helps him to make assessment better.
Yeah, but for this course, we changed it a little bit because it's a bit different from regular extended fast. For example, we have changed the order in which we're doing our examination, because normally we do bladder, Morrison, spleen, and the stuff, and then we're moving directly to the heart. We have decided, well, at least for us, that it will be more useful to start from the lungs examination, because it might be more problem for us, and also we can fix it pre-hospitally. If we have a tension pneumothorax, then we have some options at least. So maybe it's not a big deal, but well, we'll see. We will try to play with that. Maybe it will work out.
Also, this course adds some thinking about not only that you're doing in this moment, like you run in eFAST, but also hypothermia prevention. You need to always remember about this. You need to use gel, how much gel you're going to use. You running low on supplies. You need to think about hypothermia, always cover your patient, and so on, so on. So it's not the regular extended fast in let's say ICU. It's about you are in really shitty environment and you need to think keep a lot of things in your head. So this is a tactical APUS.
Yeah. Also, probably how to take care about your growth in the mud when you're working in I don't know, in a snow, in a heat, and so on, because you're working not in the hospital.
So one change that we introduced is the hypothermia. So we are aggressively covering our patient, all of our patient, whilst we're doing the eFAST. And so many other ultrasound courses I've attended, the person just half in the nip, half naked, and they got gel all over the place, and no one cares because they're in the classroom, and that is a training scar. So what we do, and we do very strictly, is to make sure that patient is covered, and we only uncover the part of the body that's currently being scanned. How applicable will that be in the trenches?
I'm not sure about that application of actually eFAST in a trench, directly in a trench. It might be dangerous, but otherwise, this might be a casualty collection point. This might be some more safe place, and yeah, it's so applicable. It's need to be implemented on all levels because we saw a lot of casualties that was not heavy wounded, or they have hypothermia, and their status were really bad. And when you're going to use your probe, when you're going to perform eFAST, thinking about hypothermia, thinking about cover your casualty, thinking about that gel is a substance that go to make hypothermia worse. You need to take all these things in your head. It's also about you have some clothes on your casualty maybe, and you need to also think about not to make it wet. If it's wet, what I can do, how I can cover this body part to make it dry. So it's not only about how to find the kidney and a spleen or something. It's also about the philosophy that's going to be performed in a really bad environment without any cover, without any additional hit, and when you're really running low on the supply.
I think at all courses and all levels, all medics, I don't know why, but they always forgot about hypothermia. And that is why it is very important to remind him about hypothermia in each course.
Excellent. I'm glad you guys brought that in. And there's another contentious thing that you guys changed, and I didn't think about that. Vlad and yourselves had a new idea on the method of doing an eFAST. So we always start at the bladder, and the reason we do that is because it's the easiest thing to find. If someone hasn't done one for a while, everyone can find the bladder, and then it gains confidence as they go through the system. But And there's a profound amount of blood that would be around the bladder for a pelvic fracture or a belly injury. Then we do the liver with the Morrison's pouch, and then we do the spleen. And here is the contentious. And there's going to be so many very cross people with what you've done, but you skipped the heart. You went from the spleen to the lungs, and then after the lungs are finished, you went back to the heart. So why?
Well, first of all, because again, if we're talking about CLS and CMC level students, that takes them a lot of time to like have a good picture when we're talking about cardiac, and we would love them to learn equally, like in the best possible way, all the spots we're talking about, but probably lungs and potential tension pneumothorax in our combat environment is a bigger problem. And I mean, like, we just have it more, frequently. And again, we can deal with that pre-hospitally, because at least if we find a tension pneumothorax, we can do something and we can start like preparing for this procedure as soon as we have found it. Yes, we need to finish our examination, but I can ask my colleague to start preparing for decompression or thin-gritty or whatever level you are at. But with the cardiac problems, you can only do what? Telemedicine. That's it.
So I really love the idea that eFAST that we do in sequence. It's a good thing when you in stress, you have like direct sequence and just running this like multiples from some point to other point to other point. You have a strict map, but sometimes you change this order because you're not using this tool, and eFAST is a tool, like without clinical, see the clinical of your patient. You think, you analyze, you're going to assess your casualty, and if you see like obviously some wounds on the chest, it's much more sense start with the lungs, not with the bladder. So you like using these tools, and after you done with one point, you go into another. And I love thinking about this more about like it's as a thing that you need to check, and you need not for and you don't forget about it, but you also can apply your tools in the best way for this casualty, not for the protocol or something.
I think this direction nice because combat medics most likely can something do with internal bleeding or tension pneumothorax, but it's very difficult to do something with the heart on the battlefield.
I like this approach. I like the fact that the heart is last, because there isn't anything we can do. I'm a critical care paramedic, and yes, I've done pericardiocentesis, but never alone. And even when we drain the heart, the blood around the heart, you've got coagulopathy, you've got clots, you can drain it, and it's just going to bleed again. There's nothing really that you can do about blood around the heart and tamponade. So I think you guys are very clever on focusing on what can be fixed. Now let's talk about your heart views. And this week I was doing a scientific study. I was doing a pre-post Delphi study on the two views of the heart and seeing what the students would be better at doing, either the substernal or the PLAX, the parasternal long axis. And you guys were with the students. So tell us about your experience with the two different views from the heart.
So our experience from these trainings, it's from my perspective, it's obvious is that they have performed easier to make a good picture of the heart from a parasternum view, and they really struggling to make a good picture sometimes by the substernal view. So for in my humble opinion, it's bad if you have a lack of time, you have maybe even non-medical personnel, you can just keep substernal view and make the things that they going to perform on each casualty, then like then given the tools that they can apply just on some percent of the casualty. So from my perspective, it's easier to teach working with parasternum and long axis than trying to give the good picture from substernal.
Yeah. To be honest, we quit doing substernal view in our medical practice. We're doing only parasternal, but we kept teaching it. I don't know why. Probably because it's still in the guidelines.
Yeah.
But now definitely we will quit teaching it too, because it doesn't win time for you. And again, we're talking about people primarily without non-medical background. So maybe instead of like over feeling their brain with the tones of different views and spots and so on, we can give them one which will work the best.
Also, if you're talking about from the perspective of the training, they start doing bladder, it's easy. They start doing Morrison pouch, it's also easy. They're doing spleen, it's a little bit harder from them, but they also prevail here. They're doing lungs fast, perfect view. And after that, they start working the cardiac from the start to substernal, and you see like they're struggling. They like feel that like, okay, I understand what I need to do. And here is like something that like really stuck. It doesn't work on this casualty or this patient or model, and they really like have some lack of attitude. So when we done one experiment, they start like bladder, Morrison, spleen, lungs, cardiac, but prayer, parasternum, and you like see that this person like feels the confidence that they go and perform it in some other environment. They feel that confidence from this training, so that okay, I understand that I need to practice more, but at least I can do it. I have that feeling that I prevail with this.
Substernal view is very difficult it's very difficult for students. It seems to me, because they don't understand how to put the hand with the probe under the sternum, and it is more easier to put parasternum just after the lungs, just slowly sliding lower than they make lung.
I haven't plugged in the data from today's study, but the first 2 days, it's very obvious that the parasternal long axis is far superior view for these nurses who came through this program. And I would be very interested in hearing from Yi on how this is picked up by the Combat Lifesavers and seeing if they are getting parasternal long axis views pretty consistently after a 6-hour tactical APUS course.
Yeah, we'll see.
Yeah. So the last 3 days you were teaching Mater Dei nurses. The college has been supporting them for over a decade, and we brought them in to challenge you, to give you some difficulties. How was that experience teaching this tactical concept to Maltese nurses?
That's not a fair question because they have all medical background, their own nurses, and that was easy, super easy. Because in Ukraine, teaching people without medical education, no medical background, it's pretty challenging sometimes. And sometimes you're stuck at some tiny details which are like supposed to be obvious for people, but no. So, but from the another side, it's like really unpredictable because like you think that you are prepared for the course, you think that you have all the answers, and then kaboom, they're asking you some question that just like bumps you out, and you're like, okay, I didn't even know how to explain that. So that was pretty easy to teach local nurses, and also we're really grateful that they supported us in that.
Yeah, it's first of all, we're grateful for them being here for us. It's really like an honor to teach him and medical personnel. It was an interesting experience, but also a lot of like funny situation. We during lunch and like here we can see maybe tension pneumothorax and one of the nurses. Oh, I got this one yesterday on my shift. Like, oh, nice. And the challenge here, like it was, I think for part of the team, it's that you need to perform everything in other language, but otherwise, like it's pretty comfortable environment to train to train other people. In Ukraine, I think it will be harder because like here nurses understand the anatomy, they understand what in basic ultrasound is because they already hear about this. And in Ukraine, you need like uh, unfortunately, sometimes, let's say, sell this idea that they could use this in a proficient way, and like you need to start from selling the idea of eFAST in the trenches, and after that you need to perform, and after that you need to learn, teach them understanding of basic anatomy. So it will be harder, but at least we have now like great tools like home points. It's great thing. It's really easy, and I love it. Home points. You don't know what to do. Go at home. You
Go home.
go home. You get lost. Okay, go home and like make a few moments. So it's much easier to, at least from the performing eFAST perspective, to conduct further training.
Oh, it's for me, it was a very difficult challenge because and first time in my life, I study students in English. It was very difficult, but it was easy to teach medical persons because they know anatomy, and it was too easy to explain them some things.
So in medicine, we like to ask a couple questions. And the first one is, could we do something? And the next question is, should we do something? So yes, can we teach ultrasound to combat lifesavers? Yes. Now the question I want you to answer is should. How is this knowledge for someone with 5 days of medical training, how is this going to better the troops on the ground?
The reason why we asked Quorum to support us in this, pretty new course, because, again, the evacuation in Ukraine is really prolonged. And normally people who are working like in a combat environment, even if they're combat medics, um, they're challenging this prolonged evacuation because you need to know like a lot to support your casualty who's stuck wounded for a few days or weeks, and then not to let them die. So this tool is like really helpful because it's super easy. This is not a rock science. You don't need like, I don't know, 12 years in math school to do that. And even CLS can do that and ask for help through the telemedicine. Maybe they can't treat them, but at least they can ask what to do, and they will be supported in this situation.
So let's say it's a good idea to teach your soldiers before they get stuck in the DLSS. Sorry, but like one of the really famous unit become for ideas, so they don't need to teach all the combat lifesavers for deep understanding of everything, but they can teach them how to perform something. So this is the same idea. You maybe not understand how to interpret Eldon test, but if you can do this, you can make photos, send it to chat, maybe like put it on with your casualty and casualty card to evacuation points. So it's about saving time. It's about triage. It's also might win some needed minutes, maybe hours for the casualty. So it's not like game changer, but by itself, but it can help to save a lot of lives.
Can this be a tool for triage? So you have 3 casualties all at once. By giving your Combat Lifesaver, Combat Medic Corpsmen this ability, will you then be able to assess which one to transport first?
Well, yes, for sure. And also it will save you time because you can start the procedure even before the examination is finished, because you can tell someone to start preparing for some procedures. Meanwhile, you are doing the next one. And then in the very end, someone will be not like treated, but supported, let's say so, before the evacuation. Definitely.
Yeah, it's a really good tool for triage. You like someone performing or triggering the casualty, you can start eFAST on another casualty, and like you see, we have here a huge problem. Someone can start preparing to deal with this problem. So it's about saving minutes. It's about triaging, and also if you have additional time to teach your let's say second day to teach them to make an Oculus exam. Like in Ukraine, it will be so needed because almost all of the trauma associated with the blast and head injury, and you don't know what the hell is going on inside his cranium, so, inside his brain, and these tools, it's maybe the only thing in that's in tactical environment that can help you to assess are there any intracranial pressure or not. And for someone, it might be so crucial to give the chance to live. So yeah, it's a tool that could change like a lot in some situation. Sometimes it might be about health. Sometimes it might be about like.
Yeah, I think for CLS it's a very nice tool because, for example, when casualty have altered mental status, it's a nice opportunity to check what happened with this casualty. For example, internal bleeding. So the drone can put on the plasma, for example, and it helps for this casualty.
My final question for you is this. What advice do you have for anyone else out there who wants to learn a bit about the use of ultrasound in tactical environments by combat medics, combat lifesavers, combat paramedics, combat nurses?
I think teach or not to teach, it's only one problem. It is an expensive of the probe, and any reasons not to teach APUS in tactical APUS.
Yeah, if someone is saying that you are not supposed to have some knowledges because aren't now not good enough because you didn't have 12 years in med school or whatever, okay, let it be so. Agree and then learn.
This practice make you perfect. It might be not so easier when you start, but as more you change the anatomy of different models, casualty patients, the easier it's going to perform in really difficult environment. So it's about practice.
I'm glad you mentioned practice because that's how I learn. It's repetition. It's doing the sight picture again and again and doing the scan with the hands. And there's a reason that I asked for us to have 3 one-day tactical APUS courses, because it just forced you guys to do this again and again and again, and moving that knowledge from your head down to your hands. And 35 years of being in EMS. It's about hand knowledge and getting that repetition in. Thank you for saying that. Well, it's great to have you in our classroom, and I would imagine the three of ye will be back, and perhaps we'll meet in other countries in a fortnight. But thank you for being our guest, Anastasia. Thanks for being our guest again.
Thank you.
And I wish you safe travels.
Thank you.
Thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.